Okay, so I was going to start off by saying that I'm ending with a success story, but certainly my ability to upload the presentation, I think, would argue against that. In any case, this is a success story in the sense that, as Angela alluded to, only 10 years ago or less, we were talking about a median overall survival in myeloma of around 3 years. We are now more than double that, and in fact, probably even close to triple that. And more importantly, we have so many new tools that we have actually now discussed not just what a complete response is, but what is minimal residual disease. There have been a lot of discussions today about that. And what I would like to talk about is not only what it is, but what do we do with it? So this is a cartoon that I borrowed that has historically been used to describe what the disease status is. And I think the nice thing about this is that it shows that the tip of the iceberg really is potentially a relatively small part of what we're dealing with. Certainly a part of the disease that we are very capable of eliminating. What I would like to focus on is what's underneath. And you can see that we go to complete response, stringent CR, CR looking at minimal residual disease by flow, which can get down to 10 to the minus 5, and more definitively not next generation sequencing with 10 to the minus 6. And I would like to spend a lot of time during the talk about discussing what the difference is and are there differences between flow-based and next generation sequencing and that difference between 10 to the minus 5 and 10 to the minus 6. I think the question of cure is a valid one. I would argue that the data so far has unfortunately told us that we are getting closer, but I'm not sure that we're necessarily quite there. So there are a few questions that I think have come out overall in the field and that I would actually also like to address that I've been thinking about specifically. When do we test MRD? As I alluded to you earlier, does the depth of MRD negativity matter? Is there an impact of MRD negativity on progression-free survival? And is that affected by treatment? And something that our group has been focusing on a lot is once we get to MRD negativity, what do we do? Are there strategies to hopefully maintain that setting? And I hope to address all of these in this talk. So this is data that I think is relatively interesting because first of all, you can see that there were two strategies that were used to look at it. MFC stands for multi-flow cytometry, and again, with a threshold of 10 to the minus 5, and then on the right side is next generation sequencing, 10 to the minus 5. And I think there are basically 2 points that I want to make here. The first one is that the doublet, which in this case was carfilzomib plus Revlimid, compared to Revlimid alone, overall did better than single agent Revlimid. But the other important thing here is that the MRD negativity achieved with a doublet appeared to be better than the MRD negativity achieved with Revlimid alone. So specifically on the left, if you look at the yellow versus the green curves, and similarly on the right, when you look at the yellow compared to the green curves, you can see that there's a considerable difference and discrepancy between patients that have theoretically achieved that 10 to the minus 5 negativity. And yet with a single agent, they don't do as well. So then the question becomes, is it because with the doublet, you're actually getting deeper than that and just not able to detect it with this assay? Or is there something unique to multiple drugs? This is another study that addresses this question, and now really looking at the second generation, if you wish, a triplet compared to a doublet. And as you can see here, and this is in the relapse setting, that with a triplet, there is a higher percentage of patients that are getting a stringent CR and in fact MRD negativity, and that this was true as patients were given this triplet earlier on in therapy. So again, I think the point here is that one of the ways that we have to up to 2021 been able to get better responses is because we have individually highly effective drugs, and we're seeing that in combination with these drugs together, we're getting deeper responses. And I think this is a conversation that came up in earlier questions, specifically with regard to the CAR T cells. Is there a benefit to earlier therapy, to moving a lot of these therapies up front rather? And this data would at least appear to suggest that with one line of therapy, patients did better than with 2 lines of therapy, despite the fact that these are the same drugs. So this was the Forte trial that Angela also mentioned, and I've summarized it as well, focusing not so much on what she mentioned, which was basically the idea that KRD plus transplant was the winner in this, certainly compared to carfilzomib, cyclophosphamide, and dexamethasone with transplant. Really, I think highlighting the point that a proteasome inhibitor as well as an IMiD is the way to go right now. But that even afterwards, with the second randomization, so basically patients underwent transplant, were given more consolidation like that, and then randomized to either getting 2 drugs, carfilzomib and Revlimid versus Revlimid alone, that there was a benefit for the doublet compared to the triplet. But on the bottom in red, what you can see is that there was not only a benefit in terms of progression-free survival, but that correlated with an improvement in a sustained minimal residual disease negativity. So you can see that KRD had 68% versus 45% in the KCD. And another trial, also mentioned by Angela, was the randomized French and Dana-Farber 2009 trial, which really was the first big trial to answer the question of, in the era of new drugs, is there still a role for transplantation? And the schema is here with only 12 months of lenalidomide maintenance. And if you go to the next slide, please. MRD was obtained at that, no, go on, that's okay. Next slide. MRD was obtained after transplant and before maintenance. And the point that I want to make here is that they did this with next generation sequencing. And so you can see that they went down as low as 10 to the minus 6. First point. Second point is, not unsurprisingly, there appeared to be a linear relationship between how deep the response was and how well patients did. So as you can see from this, patients that got down to less than 10 to the minus 6 had the best progression-free survival. And in contrast, patients that had more than 10 to the minus 4th had the least favorable survival in this. So this, I think, would argue that with this highly effective therapy, the deeper the MRD negativity, the better you will ultimately do. But the interesting thing in this study was, again, that the MRD negativity was down to 10 to the minus 6. And what you can see here now, in contrast to that first slide that I showed you that was just looking at 10 to the minus 5, that it did not matter whether you got a transplant or not if you achieved MRD negativity. So if you look at the MRD negative transplant, which is the purple line, compared to the MRD negative RVD, which meant that they did not have transplant, those curves are completely superimposable. Now, if you look at the other 2 curves, the patients that remained MRD positive, the transplant arm did better than the chemotherapy arm alone. So the way I interpret this data is that transplant can clearly has a higher likelihood of achieving a deeper overall response rate. I think this has been shown by the fact that there's a higher MRD negativity, there's a higher complete response rate, and there's even an improved progression-free survival rate. I mean, also the fact that you see the slight difference here, but with 10 to the minus 6 as the cutoff, and I think this begins to be a cutoff where we're seeing real differences, the disease cutoff and the ability to achieve that low disease burden is irrespective of what the overall burden of disease, the overall therapy is. And so as such, the patients do well, whether they got transplanted or not. So this becomes a question, I think, with regard to some of the CAR T cell studies. So this was the BB2121 that Nupur mentioned in her talk. And what you can see from this study is that there was a median progression-free survival on the left of 11.8 months. But if you look at for all comers, but if you look at the MRD negativity of the PFS for the patients that achieved MRD negativity, it increased, but it was still a finite number. So you went from 11.8 months to 17.7 months. Even with an aggressive therapy such as CAR T cells, and even with the ability to achieve MRD negativity, what this is telling me is that we are not eradicating the clones that ultimately are responsible for relapse. And this may be something very unique to myeloma itself, because certainly if you take the results from CAR T cell trials in acute lymphoblastic leukemia, especially in children, as well as in diffuse large cell lymphoma in adults, the patients that get to MRD negativity pretty much have a plateau and are possibly cured. I mean, we're seeing sustained disease response rates going out 4 or 5 years. Myeloma is a very different story. So what are we able to do once we get patients to this MRD negative state that can potentially alter the overall biology? And to my knowledge, we as a field have not really begun to talk about this a lot. However, our group has begun to think about this. And so I would just like to take these next few slides to talk about a trial that we finished and a trial that we currently have ongoing that really, in my opinion, I think is the first one to address how to treat MRD negativity. So this was a trial that was open now, that was started about 10 years ago. And what we did at the time, and our definition in 2011 of MRD negativity, were patients that had achieved an undetectable M spike, but still had a positive immunofixation, and that positive immunofixation had to be there for about 6 months. Then we gave patients 4 vaccines in this setting. Oh, and I need to mention that these patients were on a Revlimid-containing regimen. And so the idea was, if we could vaccinate these patients that had a sustained near complete remission with immunofixation positivity, could we alter the biology of this disease and actually drive the disease further into an immunofixation negativity? So we did this trial with a total of 15 patients, and what the trial required was that patients, as I mentioned, had to have this near complete remission that was sustained on a Revlimid-containing regimen for at least 6 months. Then when they enrolled on the trial, they stopped all drugs except Revlimid because of the immune potentiating effects that Revlimid actually has. And then they went on to receive a series of 4 vaccinations given at 1, 2, 3, and 6 months. And we looked at the ability of this vaccine to elicit a myeloma-specific immune response. And so on the left are the 2 cell lines, myeloma cell lines that we used as part of the vaccine. And the thing that was very surprising to us is that, as you can see at baseline, and not surprising, there was virtually no evidence of anti-myeloma immunity. By the 3rd vaccine, we already saw evidence of anti-myeloma immunity, but the thing that was amazing to us is that extending this out for greater than 4 years, and I can tell you that we have patients that are out 8 years now, that immune response has been sustained and in no way actually waned. If you focus attention on the right side of the slide, that pattern is pretty much superimposable. The difference being that with those 2 cell lines, these were lines that were not used as part of the myeloma vaccine. So what this data is telling us is that we are generating with our vaccine an immune response towards myeloma antigens that are independent of the vaccine, but what we otherwise would tend to call shared myeloma antigens. And again, that we're seeing this very sustained response. And these are our Kaplan-Meier curves. So what we see here in terms of progression-free survival is that we are out now over 8 years and have not yet reached our median progression-free survival. But in contrast, if you look at the overall survival, we see that we have reached it. So this is a very interesting thing and something that I'm very proud of. But we actually have patients that have died on the study, not of myeloma. They were vaccinated and have done so well that they've died of heart attacks, they've died of old age, they died of other things. And so this is one of the few situations that I personally have been involved in where our overall survival is actually inferior to our progression-free survival. But the interesting thing here is, what was the role of MRD? So what you can see here is that we used the adaptive next generation sequencing. And when we were able to obtain MRD on the patients, we could see that at baseline, at the time of starting the vaccination, patients that had a higher MRD burden were the patients that had a higher likelihood of relapsing, which again is not surprising, but nevertheless, that's what we saw. But the interesting thing, and this is what I would like to bring up, we have this amazing progression-free survival curve. But what I'm showing here are the M spikes of a lot of these patients that were on the trial. And you don't need to be a myeloma expert to see that those numbers are not zero. There are some, for example, patient number 1, that's the blue circles, that is continuing to be zero. But there's a lot of other patients that sort of go up and down and have measurable disease. And in myeloma, the definition of relapse is when you go from a complete remission is an increase of at least 0.5 that is repeatable at least 2 time points. And so you can see that a lot of these patients have not reached that threshold, and in fact have what I call a myeloma MGUS conversion. So in other words, I think what we have done has been to convert this active aggressive disease into a very indolent disease that is just sort of sitting there. And I think the reason why this disease is sitting there is because, as I've showed you from the earlier slide, we have a sustained active anti-myeloma response. Again, that is going out in some patients as far out as 7 to 8 years. So if we are able to control the disease, once we've been able to get it down as low as we can, I think we can really make a significant impact on the overall disease burden. And I think one of the problems with the lack of sustained responses in CAR T cells, that 17.8 months, even in the patients that have received that got to MRD negativity, is that CAR T cells, one of the major problems that they have in their current formulation is lack of persistence. We are unable, at least from the data from the BB2121 in that format, we are really unable to detect T cells much past 6 months and certainly not past a year. And if we're going to take a chronic disease and not completely eradicate it, we have to maintain, in my opinion, a chronic therapy, which is why I think Revlimid has done such a great job, because we've gone from giving it for 4 months, like cytotoxic chemotherapy used to be, to giving it for years going on out. So I just want to conclude with this slide. This is the trial that we currently have ongoing that really tries to answer the question of whether these data that I just showed you earlier are something that would hold up in a randomized fashion. So we currently have this trial of 54 patients where it's a 1-to-1-to-1 randomization. But you can see here that basically 2/3 of the patient are getting the vaccine itself, the myeloma vaccine. We're also giving Prevnar, and if somebody wants to know more details about that, I can mention it either privately or during the discussion session. But for the most part, it's a 2-to-1 randomization for the vaccine. I've listed the eligibility criteria here for anybody that may be interested and potentially eligible. So you have to have non-high risk myeloma. You have to be on a Revlimid-containing regimen and either in a near complete remission or a complete remission. So basically your M spike has to be 0. And then what we're doing is we are taking the bone marrow and sending it to adaptive to look for MRD testing. And we are only accruing patients that have 10 to the -4 or more copies. And the reason for that, and I sort of glided over it when I showed the data earlier, but those are the patients that have a significantly higher likelihood of relapse. And so we wanted to design the trial in a way that we would actually be getting a relatively quick answer. And so that's why we have the 10 to the -4. And then the vaccine study itself, as you can see from the outline, patients would continue on whatever dose of Revlimid that they're on as long as it's 15 milligrams or less. And these are the vaccines that are given. So 1, 2, 3, 6, and then 12, 18, and 24. And we're following them for progression-free survival. So for people that are coming from out of Baltimore or out of Maryland, it does require some traveling. But again, it's not all that much if anybody's interested. And that's all I have to say. Thank you very much. Oh, I guess, so let me finish. All right. So these are the points that I hope to have made. Does the quality and the number of drugs affect the therapy in terms of MRD outcomes? And we can talk about this, but it does appear to be the case. Is there a clinical utility for MRD at 10 to the -5? I would actually argue that from the data that I've seen, really what I focus on is 10 to the -6 as something that has a clinically meaningful response. Is the positive impact of MRD a result of the depth or duration of that response? And I would argue potentially both. You want to get down to 10 to the -6 and hopefully want to keep it down as long as you possibly can. And in terms of keeping it down as long as you possibly can, we at this point believe that an ongoing active immune approach, such as a vaccine approach, could potentially alter the natural biology of the disease and really begin to treat MRD positivity as opposed to getting to MRD negativity. So thank you for your attention.